started the timer, and here is your question.
Okay.
Right. If you have read and understood, let's begin surgical administration. Can you please identify the structures? What is this that you're looking at?
Okay. This is a CT scan of the upper abdomen.
Okay, good. Would you be able to identify the structures labeled A to E? What is A?
Okay. This is gallbladder. B.
Very
This
good.
is B. Biliary tract. C. Superior mesenteric artery, and D. Left lobe of the liver, and E. Tail of pancreas.
Yeah, the body of. Okay, good. Can you tell me what are the parts of the pancreas? What are the parts of the pancreas?
Ma'am, I
Head.
cannot hear.
Yes, what are the parts of the pancreas?
Hello?
Yes, can you hear me? Parts of the
Parts.
pancreas. Head,
We can hear,
neck,
ma'am.
Okay.
head, neck, and
Okay.
then yes, please.
Yeah. The neck, head, and contain anesthetic process projected from the head and neck and body and tail.
Good. Okay. What are the cells which are present in pancreas, and what do they secrete?
Yeah. Alpha cells secrete and beta cells and delta cells secrete somatostatin, and B cells secrete pancreatic polypeptide cells.
Can you name the sources which give the blood supply to the pancreas?
Yeah, the blood supply of the pancreas duodenal artery from gastroduodenal artery, and the inferior pancreatic artery from superior mesenteric artery, and pancreatic branches from the splenic artery.
This pancreatic or duodenal artery is branch of which vessel?
Yeah, the gastroduodenal artery branches from the hepatic artery.
No, I asked inferior pancreatic or duodenal artery. Okay.
Inferior pancreatic from superior mesenteric artery.
Yes. Okay. Can you tell me the landmark where superior mesenteric artery arises from aorta? At what level?
Arise from the abdominal aorta at the level of the lower border of the L1.
Okay. Can you tell me how many ducts there are in pancreas and where do they open?
Yeah, to mention ducta, main pancreatic ducta. This is called Wilson ducta. Open combined with the bile duct with the main pancreatic ducta to form a ampulla of fata open in the posteromedial aspect of the second part of the duodenum in the major duodenal papillae. And accessory pancreatic duct. This is called Santorini ducta. This is drain the lid of the body and the tail and above half inch above the major duodenal papillae.
Can you name the structures that one can encounter while doing Whipple procedure?
abdominal aorta, superior mesenteric artery, superior mesenteric vein, splenic vein, left renal vein.
Okay, can you please tell me what is the most important hormone, what is the most important test to consider when diagnosing pancreatitis?
What's mom?
Which test is most important to consider when diagnosing or confirming the diagnosis of pancreatitis?
Yeah. And after many tests according to Glasgow criteria or ransom criteria.
Okay, can you please tell me this if what organ, which organ would this be near E?
This is spleen.
Okay, can you tell me okay, can you tell me what are the parts of spleen histologically?
Yeah, the spleen have middle end and lateral end and upper border. The hilum content with the splenic artery, splenic and splenic vein. As physiological function in the hemolytic function, and in adult have filter of the red blood cells and the immune function by white bulb and the red bulb in the pancreas in the spleen, and can be secrete opsinin the trypsin.
Okay, can you please tell me the surface marking of spleen?
Yeah, the spleen have upper border at the line of the 9 ribs and lower border at the line of the 11 rib, and the long axis at the line and the lateral end, the vertical line from the mid axillary line, and another inferior angle of the scapula. This is the surface anatomy of the spleen.
Good. Can you please tell me what are the structures that you have to keep in your mind while doing splenectomy?
Yeah, tail of the pancreas, acute pancreatitis post-splenectomy.
Yes, why? What can happen if you injure the tail of the pancreas?
Yeah, because of the ligament attached to the spleen to during dissection of the splenectomy, and the ligation of the splenic artery and the vein can be injury of the tail of the pancreas.
Okay, can you tell me what is the blood supply of spleen? Blood
Yeah,
supply,
the spleen.
yes.
Yeah, splenic artery arise from the celiac
Trunk, yes. Then can you please tell me the whole course?
yeah, the splenic artery arise from the axis and defeated and run along the left side, the upper border of the pancreas, enter the hilum of the spleen through the lienorenal ligament. Give the branches to the and the spleen, and short gastric vessels to the fundus of the stomach and gastroepiploid artery.
Yes. What other organs are supplied by the splenic artery?
Yeah, the stomach give short gastric artery by the fundus of the
And
curvature of the stomach, and the give pancreatitis to the pancreas, can be also supplied the pancreas.
yes, good. Thank you. Bella has gone. Before we go on, can you please identify these structures? What is this that you're looking at?
Okay. Identify this. Okay, mom. This is a CT scan of the upper abdomen. Identify A, this is inferior vena cava. B, rector spine muscle. D, portal vein. D, right cross of diaphragm, E, superior mesenteric artery, F, fundus of the stomach, and G, abdominal aorta.
Very good. Okay, thank you so much. Started the timer, and here is your question. Right. If you have read and understood, kindly begin your examination of cerebellum.
Okay. After entering the room, I'll wash my hands and
Yes.
introduce myself to the patient and confirm the age and name and age of the patient.
Yes.
Take the permission from the patient to examine his nervous system and reflexes by looking, feeling, and moving the arms and legs. And I'll examine the patient in a standing, sitting, and lying down position. First,
Good.
I'll request the patient to stand up, and I'll test the Romberg sign. First, I'll ask the patient to put the feet together and hands on the sides and eyes closed. I'll assure the patient that I'll support him and not let him fall. And then I'll see if the Romberg sign is positive or not. And after that, I'll ask the patient to open the eye and then ask him to walk a few steps so that I can see the gait, and then walk on heel first and then
If
on toes first.
Patient is having
I-
cerebellum disorder. How would the gait be?
Yeah, if patient will have cerebellar disorder, there will be broad-based gait,
Yes.
and also patient will have unsteadiness when I'll ask him
Good.
to walk in
Yes.
tandem with heel to toe
Good.
in a straight line. He'll be unsteady. After that, I'll ask him to sit down on a chair or on the bed, and then I'll ask to say like British Constitution or hippopotamus to test the staccato speech. And
Okay.
then
How would you do that?
I'll just ask the patient to pronounce like British Constitution
Yes.
or baby hippopotamus.
Yes.
And then I'll check the extraocular movement of the eyes. First, I'll ask the patient keep the head and move only eyes and follow my index finger. Move my index finger in H-shaped and see if the extraocular movement is normal or not, if there is any nystagmus present or not.
If it
And
would be posted, so what features should there be?
there might be presence of, or there may be not, but maybe nystagmus.
Okay. Yes.
I'll then ask the patient to open the mouth and say ah, and also ask to cough, so that I'll 9th and 10th cranial nerve I can test, and to test the 11th cranial nerve I'll turn the against resistance of my hand, also shrug the shoulder against the resistance of my hand. After that, I'll ask the patient the tongue and then touch and against my finger outside while tongue inside, and through this I'll ask the hypoglossal nerve. I'll ask the patient if he has any pain in the upper limb, and I'll going to move it, and if it is okay with him, and then first I'll see the tone of the upper limb. I'll support the patient's arm by holding it at hand and then an elbow, and then ask the patient to relax and let the arms completely over my control. I arm passively through the full range and see if it is a smooth or there is some resistance. After that, I'll do the reflexes, especially biceps, triceps, and supinator reflexes to see if it is normal or any abnormalities there. After that, I'll do the pronator.
What abnormalities are you expecting when doing the reflexes, limb reflexes?
In reflexes, it will be normal, ma'am. In cerebellar disease, it will be normal.
It's often mild hyporeflexia. Okay. Yes. Next.
And then I'll see the pronator drift. And pronator drift, I'll ask the patient to close the eyes and place the arms outstretched forward, palm facing up. And then I'll see if there is any slow or upward drift on either side. If there will be any upward drift on the side suggestive of the lesion in the cerebellum. And then I'll ask the patient to close the eyes and again place the outstretched arms, and now keep the arm in the position when I'll press it down, and I'll see if there is any rebound phenomenon present. If arm shoots up above the level original position, then it is suggestive of cerebellum. Okay. Then I'll do the finger to nose test, and for that I'll ask the patient to touch his nose with the tip and then touch my fingertip, and I'll move the finger as a moving target, and I'll see if he can do it or not. This will assess the coordination, and also there will be any intestinal tremor will be obvious in this test. And next, I ask the patient to tap the palm with one hand with the back and then with the palm rapidly, alternatively rapidly. And this will test the dysdiadochokinesia. And
good.
Then I'll request the patient to lie down.
Okay. Can you sum up your case now?
Okay. To complete the examination, tone and reflexes as well as coordination of the lower limb also. And I'll thank the patient, help the patient to get dressed. And I asked if he needs any limb, I'll ask the hand. Now to complete the full examination, I'll do the complete neurological examination, including the cranial nerves and neurological examination, both upper and lower limbs.
Yes.
So today I have examined this gentleman who presented with the symptoms, of posterior cranial fossa tumor. On examination, I have noticed the patient has broad-based gait and also unsteadiness, and he is unable to perform the tandem gait. There is a negative Romberg sign and negative staccato. And
so this makes you give what differential diagnosis?
On the basis of my examination, I'll make the provisional diagnosis of cerebellar ataxia due to posterior fossa tumor. My differential diagnosis will be some cerebellar metastasis from lung cancer or another area. There may be head trauma or a cerebrovascular accident or multiple sclerosis or even transient ischemic attack.
How should this patient be managed?
I'll manage this patient by first offering the investigations, which will include the complete blood count, urea electrolytes, as blood glucose, and as also blood grouping and cross matching, and then advise the imaging, which include the plain skull, which may show some calcification. And then I'll do the MRI brain with gadolinium scanning, and then we'll see if there any abnormality in that, and also do the CT brain, which will be
what do you expect to see in that?
Help in the post-operative follow-up.
What should be the treatment for this?
After discussing the case in the multidisciplinary team, after proper MRI imaging and biopsy and discussing multidisciplinary, we'll offer the patient excision of the tumor.
Good. Okay, you mentioned if time would have allowed, you would have done a leg roll. How can you do that? How would you have done that?
To see the tone of the lower
Yes.
limb, we do the leg roll of the
Yes.
patient.
How would
What
you
we do that, we do the leg roll and see if the foot is flopping independently of the leg or not. If it is
Okay.
flopping independently, that means there is no increase.
Good, good. Now that is done. Thank you.
Thank you, ma'am.
Yes. Any feedback? Yes, you would have thanked the patient and you would have helped the patient
Yeah.
sit, and then you can, yeah, that.
Yeah,
small
actually,
thing. And wash
I
your
should
hands
have.
at
Yes.
the end as well. So these are the small things that you have forgotten. So maybe. if you
Yeah,
can
actually,
just move-
time passed, so I
Yes,
said that
so-
I'll thank.
Yes, good. Thanks. Start with the timer, and here is your question.
Okay.
Right. If you have read and understood, kindly tell me how, considering it critical care scenario, how would you manage the nutrition of this patient?
Okay, manage the patient according to ABC approach of the CRISP protocol after airway assessment and the treatment and breathing assessment and the treatment and circulation assessment and the treatment. My professional diagnosis could be small bowel obstruction secondary to a structure of the Crohn's disease, and another differential diagnosis could be a small bowel obstruction, and could be ischemic colitis, and could be septic shock. The manage the patient with the nutrition in this patient. The nutrition in this patient can be intra and the parenteral. The enteral could be oral, nasojejunal, nasoduodenal, and nasogastric, and the endoscopic gastro and endoscopic gastric tube, and the parenteral by total parenteral nutrition can be given in the central and the peripheral.
Okay, can you please tell me how would you calculate the nutrition that should be given to this patient, and how would you give?
Yeah, they'll calculate by nutrition for this patient.
Yes, please.
Normally by 30 calorie every kilogram. In patient have 70 kilogram, but post surgery regard this case post structure of the Crohn's disease, the calorie 35 calorie every kilogram increase by 10% per degree increase in the temperature.
Okay, very good. You mentioned that there are two types of methods of nutrition. Can you give some examples to justify what are the examples of parenteral and or enteral nutrition?
Okay, non-parenteral nutrition could be oral and nasogastric, nasoduodenal, nasojejunal, and jejunostomy and percutaneous endoscopic gastrostomy. And parenteral feeding by total parenteral nutrition could be total and could be partial.
Okay, what do you understand by total parenteral nutrition?
Yeah, this is nutrition of the feeding via intravenous route to give the nutrition to sufficient the supplement of the daily requirement of the patient.
Yes, What is the source of carbohydrate in TPN, total parenteral nutrition?
What's mom?
What is the source of carbohydrate in TPN?
Yeah, glucose. And
Okay, what
another
are,
source.
yes, what are the other,
and
yes, source?
Another source could be the fat and could be protein.
Okay, good. What are the other constituents of TPN, total parenteral nutrition? What other ingredients?
What's mom?
What else is there in TPN other than glucose?
Another component, carbohydrate, fat, glucose, vitamin, and the trace element, and nitrogen.
Yes, how much vitamins there are? Trace amount.
Vitamins A, B, C, and D, and K.
What are the methods of giving TPN?
Yeah, given by the central line.
Okay. If central line it cannot be reached, can it be given by any other ways?
Yeah, can be given peripheral
Peripherally, yes.
and the central. But
How the
yeah, can be
monitoring,
given peripheral and
yes.
central. But the
How monitoring should be done once TPN is given?
yeah, given by central better than peripheral, because risk of that thrombophlebitis of the blood vessels. Monitoring by glucose more than once daily, risk for hypo and hyperglycemia, and they can be monitoring more than once daily in urea and electrolyte and creatinine, and can be monitoring of the albumin and calcium and phosphate and magnesium and liver function test by twice weekly, and the body weight and the urine output daily, and the weight every week.
What test would you ask for to confirm that nutrition that you're giving to this patient is adequate?
Yeah, assessment of nutrition by most score and history, any history of nausea and vomiting, and history of any chronic illness, and the social history, very important, income of the patient, and the examination by mid-arm circumference and the biceps fold thickness and the triceps fold thickness, and the anthropometric measurement and the dynamometric measurement, and the investigation like full blood count for any anemia, and the shift of neutrophil and urea and electrolyte and liver function test, and the albumin and the immune function.
How would you know if patient is suffering from malnutrition?
Yeah, low albumin and the antibody lead to poor wound healing, and acidosis, hyperkalemia, and decreased cough reflex lead to pneumonia, and thick and dryness of hair.
Good. Can you please tell me the difference in dextrose and sugar? What is dextrose? What is sugar, please? Yes.
Yeah, dextrose is simple sugar made from corn and chemically identical to glucose or blood sugar used in baking products as sweetener and corn syrup. But the sugar, this is sweet short chain soluble carbohydrate used in the food preserve composite of the carbohydrate, and they classified as simple sugar as monosaccharide, as glucose and dextrose and the galactose and fructose and the sucrose, and the disaccharide as sucrose, hydrolyze of the sucrose into fructose and the glucose. Other disaccharide like maltose and lactose.
Thank you. Can you please tell me what are the complications of total parenteral nutrition that we should be careful for?
Yeah, complication as mechanical complication, as fracture, blockage, migration, displacement, line, a complication like pneumothorax, central vein thrombosis, air embolism, hemothorax, hydrothorax, and cardiac arrhythmia, and infection complication like sepsis and infective endocarditis, and metabolic complication like hyperglycemia, hypoglycemia, hypertriglyceride and
Good.
hypercholesterolemia and hyperchloromic metabolic acidosis and
Good.
abnormal liver function test and the
Can you-
respiratory failure.
Yes. Can you please tell me what you understand by the term refeeding syndrome?
Yeah, the refeeding syndrome, this is syndrome characterized by electrolyte abnormality occur in patient in the starvation and malnutrition, suddenly start with the total parenteral nutrition, leads to stimulation of the glycogenolysis and the glucogenesis and the lead to protein catabolism, and this shift of the switch mechanism from catabolism to anabolism lead to protein and the fat and the mineral and the vitamin depletion, leads to insulin secretion. After insulin secretion, increase the protein and the glycogen synthesis and increase the glucose uptake and the increased uptake of magnesium and the phosphate and the potassium, and so leads to hypokalemia, hypophosphatemia, hypomagnesemia, and the thiamine deficiency and salt
Okay.
and water retention.
What measures can you do to prevent refeeding syndrome from happening?
Measurement daily potassium and magnesium and phosphate and thiamine as B1.
Okay, Bell has gone, but one last question, please. When a patient has been giving TPN, total parenteral nutrition, why bowel mucosal atrophy occurs? Gut mucosal atrophy, why does it occur? Hello?
Because of absence of the enteronucleotrophic changes in the intestinal mucosa, because of local hormone released in response to of the food stimulating, leads to a release of the enzyme responsible for integrity of the intestinal mucosa and the loss of the immunoglobulin A to preserve the intestinal intact mucosa.
What can you see in this? Can you help me to read this? What is this condition, or what is this called? Can anyone else answer?
What's mom?
Yes, this arrow
cannot
is,
hear.
sorry, this arrow is pointing at
cannot hear,
something.
mom.
This arrow is pointing at something. What does this call? Is it my
Okay.
network? Yes.
This is X-ray rect abdomen showing abdomen and pelvis.
Yes, please.
Yeah. This is coin stock appearance due to small obstruction secondary to stricture of the Crohn's disease.
Very good. Okay, good. Thank you. Thank you.
Hello?
Yes, thank you. Correct.